Good morning, everyone. Welcome to our webinar, Elevate Your Allied Health E&O Expertise, Ensuring the Health and Wellness Industry. We are very excited for this webinar as we have a lot of really valuable information to share, so we hope you are just as excited. My name is Lexi Johnson. I am our professional liability underwriter here at CID Insurance, so I want to welcome you here today. I also want to introduce to you our special guest we have who will be speaking for majority of the webinar, Tyler Hamblin, who is the Allied Health Territory Manager at Kinsale Insurance. He is an expert in this area, so we are very fortunate to have him here today teaching this webinar. I also want to introduce Jacob Cole. He is our marketing coordinator, running everything behind the scenes, making sure it all goes smoothly. So moving on to our logistics. So by now, I'm sure you're all familiar with the process. All participants on the webinar will be muted, but your voice is still very important to us. So please type out any questions you may have in the chat room. We'll stop and answer them throughout the webinar. And if we don't get to address all the questions, we'll make sure to respond to you after the webinar. Lastly, there will be a short survey at the end. We really would appreciate any feedback so we can always work on improving our webinars in the future. And without further ado, let's get started. I'm going to turn it over to Tyler, who will begin with our objectives.
Thank you, Lexi, and far too kind. I'll do the best I can and try to stick to these objectives as best I can. Our first objective is to figure out what classes of business would fall under the allied health umbrella. We are going to be diving a little deeper into the previously discussed classes to understand how risks are underwritten and priced, and understand what's generally required during the underwriting process. We're here to also understand the most important coverages your insureds need and to learn from real claim examples, including their severity, frequency, and payouts. Next slide, please. So just to kind of recap, what is allied health? Allied health consists of medical facilities and human service related organizations in the long-term care, social services, and miscellaneous medical fields. Next slide, please. So current state of the market, and I know we went over this in our last webinar, but we are seeing these trends continue. We are seeing a normalizing after a very hard market caused by COVID. COVID caused a major disruption in the allied health space, and particularly within the long-term care space. And it makes perfect sense. Carriers were unsure of how these claims would be litigated, and as we all know, COVID affected the elderly population more so than any other demographic. We saw mass exits from many carriers, and what we've seen since are those markets re-entering the space as well as new markets emerging. The social inflation trend seems to be continuing as well, and the need for increased capacity is still present. What we've seen in recent months is that many of the excess markets, particularly in the social services sector, are reducing capacity, which is creating some significant disruption within the excess allied health space as well. Organic growth is continuing to take place, and submission volume simply is not slowing down. Faster turnaround time is certainly a big driver for growth, and oftentimes the broker that has the quote in hand within a few days of submitting is going to win the account. Next slide. Again, healthcare is one of the fastest growing industries in the US, which will lead to startup companies in the allied health space in need of liability insurance. We always need healthcare, and in the post-COVID era, we're seeing a large number of new ventures, startup companies, and also first-time insurance purchasers. And as we previously touched on, there doesn't seem to be any slowing down with regard to submission volume. The three major trends that we discussed in greater detail in our prior webinar are holding steady. The aging baby boomers, the shift towards telemedicine because of COVID, and the ever-growing anti-aging and wellness industry are continuing to be the main drivers of growth within our space. Next slide, please. So appetite, what falls under that allied health umbrella? Again, just to recap, long-term care facilities, assisted living, skilled nursing and senior apartments, home health agencies, group homes. These can be for the physically or mentally disabled and youth, adoption and foster agencies, medical transportation, pharmacies, outpatient clinics, surgery centers, medical spas, medical labs, medical staffing agencies, social service agencies, and homeless shelters and halfway houses. Moving on to coverages and what we should be looking for, almost every allied health organization has a GL and PL exposure. You'll hear brokers, agents, insureds, even carriers at times use E&O and PL interchangeably. Just let it be known that as it relates to what we're talking about today, we're talking about medical professional liability with a bodily injury trigger. For most allied health organizations, only having a general liability coverage will create some coverage gaps and cause the organization to have insufficient insurance coverage. Claims made versus incurrence. The majority of age policies are going to be written on a claims made and reported basis, which has strict claim reporting requirements, and insureds and agents and brokers need to be aware of. The need for abuse and molestation coverage, because we are dealing with highly vulnerable populations, i.e. youth, disabled adults, and elderly, is all the more reason that abuse is necessary as well. Next slide, please. So in our last webinar, we discussed the long-term care space as it relates to the elderly. We discussed the predominant concerns, typical claims we see, and discussed a real claim example centering around a resident fall. In this slide, I'd like to take a few minutes and discuss at a very high level some of the other quote-unquote residential risks that would fall into the allied health space. Within each, we'll be discussing the range in acuity, which is the starting point for bed rates used and how risks are underwritten. So to recap back to the elderly and the long-term care space, at the lowest level, we would see true independent living apartments. These facilities would not be licensed by a state, health department, or regulatory agency, and would have limited professional liability exposure. Pull cords, call buttons, call pendants are typically the reason why some of these risks would jump from a casualty risk over to an allied health risk. Many carriers deploy a healthcare professional services exclusion in their base GL form, which could create a gap in coverage and create a need for PL. The next level, and the one more commonly associated with allied health, would be assisted living and memory care. These facilities are licensed and inspected by regulatory agencies, Department of Social Services or Department of Health, and can also have a range in acuity. As residents approach the later stages of Alzheimer's and dementia, the care required and the staff ratios needed would exceed that of, say, a resident who needs just basic assistance with daily living activities, but doesn't suffer from Alzheimer's or dementia. Skilled nursing facilities and rehab centers or nursing homes would be the highest level of care, be where the highest level of care is provided, and you'd see registered nurses, nurse practitioners, physician assistants, and even physicians on staff. Bed counts for these licensed facilities can range from a couple, 1, 2, 3, 4, all the way to several hundred. Moving on to licensed group homes, typically these are going to focus on the non-elderly, intellectually and developmentally disabled adults, traumatic brain injury, mental health, psychiatric, and/or complex medical conditions that require nurse supervision and care. These typically follow a similar range in acuity from low-level spectrum disorders, developmental disabilities, to residents with severe medical conditions that would require constant nurse supervision. The examples I gave were ventilator care, tracheotomy care. Again, that's on the most acute level. Youth residential, and this is where there's sometimes a disconnect or a misunderstanding, but as from a carrier standpoint, we would view these as licensed group homes, again, licensed by some sort of regulatory agency. These are not certified foster homes. That's kind of its own animal. But in this category, they can also range from various degrees of behavioral issues, spectrum disorders, IDD, residents, and then also medically fragile. One other class that I wanted to hit on just briefly would be substance abuse. The American Society of Addiction Medicine, or ASAM as commonly referred to, came out with a range ranging from 1 to 4, right? 1.0 being outpatient services, no residential component here, all the way to 4.0, which would be our medically managed intensive inpatient services. We often refer to those as medical detoxification. Residential risks will range from sober living, where there's going to be limited professional liability exposure, limited professional services being offered, all the way to inpatient medical detox centers where constant nurse supervision is required and the intake procedures are often being conducted by physicians or higher level providers. Next slide, please. I wanted to touch a little bit on underwriting criteria and what a typical carrier is going to be looking for in order to try and rate up the risk and send you a quote. In this class, within the long-term care residential space, as we just discussed, is typically going to be rated by number of beds or units. Excluding true independent living, most of these risks will be written on a claims made and reported basis, and more often than not, the GL and PL are going to be packaged together. Typical underwriting documentation or pieces of information that would be asked of you are a supplemental application. Accord applications are a good starting point, but the supplemental applications are really where a lot of our questions are going to be answered. We're looking for bed counts, location addresses, level of care, staffing, and making sure all of the staff ratios, and the services being provided align with the clientele within the facility. Prior policy deck page or indication of retro date, if applicable. 5 years of currently valued loss runs, again, if applicable. License and state inspection documentation. And if this is a new venture, especially the resume of the owner or the facility administrator would be very pertinent to the underwriting process as well. Next slide, please. So in our last webinar, we discussed a fall claim, which tends to be the most frequent, but can present great severity as well. For this claim example, we're going to pivot towards an IDD group home. And while falls and bed sores can certainly occur in this setting, some of the higher severity claims for this class might also include choking claims and or bath or shower related claims, which is where this slide is going to take us. So for this claim example, this was a social service organization for intellectually and developmentally disabled adults and children. They had a wide range of service offerings ranging from in-home, home health, non-medical type care, all the way to, licensed group homes. They had some daycare and vocational training as well. Again, a large organization that had a lot going on, but this particular claim happened within the residential exposure. So the insured carried a 1 mil, 3 mil PLGL policy with a $2,500 deductible. And the plaintiffs were the family of a deceased 17-year-old severely disabled boy. This was a wrongful death claim, and they alleged negligence and lack of adequate care, which led to their son drowning in the bathtub. They requested a jury trial, and the opening demand was $500,000. Now, as we kind of work through some of the details of surrounding this claim scenario, it's important to understand that the circumstances in which the insured came into custody of the plaintiff's adopted son, as these circumstances are what ultimately kept this from trial and allowed for a settlement through mediation to be reached. So the family adopted the boy, and after some time, his challenges began to present themselves. He had profound intellectual disabilities. He also had epilepsy, which caused seizures, aggressive behaviors, and was nonverbal, but could communicate through signing. He was developmentally around 9 months old at age 11. At age 11, they moved him out of the adopted house and into the insured's custody due to some violence towards the adoptive siblings. By all accounts, and over the next several years, the boy flourished in the program. He gained weight, made substantial progress, hit milestone after milestone. One morning before school, the boy was in the bathtub and was left unattended for a period of time in which he experienced a seizure and went under the water. EMS was called. The boy was transferred to the hospital with a pulse, and after several hours, the family decided to take the boy off life support. So the reason that this claim ultimately settled for a modest amount here was the family's involvement or lack thereof during the preceding years while the boy was in the insured's custody. This ultimately kept it out of trial and was able to be settled through mediation. But it's important to understand that this type of claim scenario is more common than not within this setting, especially in the home health and residential setting as it relates to DD adults and children. We've seen these claims go to trial and have liability asserted, resulting in very large verdicts. Next slide, please. So moving on to medical spas, and I know we touched on this in our last webinar and really hit on the laser-based procedures. We're going to pivot a little bit and take our focus elsewhere, and what we're seeing is more than a trend, and it's something very common that I think everybody's going to be able to at least relate to after turning on the TV and seeing the commercials for medical weight loss drugs and semaglutide and tirzepatide. We're constantly facing new and cutting edge treatments. Procedures are on the rise, and all of these things are heavily influenced by social media and celebrity endorsements. It's not uncommon for these procedures to go viral, and every medical spa across the country is wanting to adopt this new service offering. IV hydration therapy and vitamin injections have soared in popularity, and we'll be coming back to this service specifically on our next claim example. But the new trend that we're seeing across the country right now is with medical weight loss drugs such as Ozempic and Wegovy, semaglutide, tirzepatide, again, these medical weight loss drugs. So the issues during the underwriting process that often have to be worked through and through supplemental applications and some pointed questions all center around compounded versus FDA approved medications. So this has created some concern in the medical weight loss arena, and over the last 12 months, this by and large has become the most common service offering we see in this space, and the one that gets the most attention from insurance carriers. These drugs were originally approved for diabetic patients, but an off-label use with astounding results has created a shortage of the FDA-approved medications such as Ozempic and Wegovy, and it's created a need to procure alternative options, i.e. compounded medications through FDA-approved facilities and licensed pharmacies. So this has created quite a bit of displacement within the Medi-Spa space, with carriers taking approaches ranging all the way from non-renewing accounts or declining risks where compounded drugs are being utilized to sublimiting the use of compounded medications. And a lot of this is going to center around how the drugs are compounded, where the ingredients are coming from, making sure that they're done in licensed facilities, and whether or not their chemical makeup meets underwriting criteria for that particular carrier. As new procedures surface, such as medical weight loss drugs, insurance carriers generally take a guarded approach until these potential side effects and complications become known. So we are in a TBD state as far as the medical weight loss drugs go. And again, this is a great example of the market responding and taking a generally guarded approach to it. Next slide, please. Medical spa underwriting criteria. So PL is primarily written on a claims made and reported basis with some exceptions, and generally rated on revenues or procedure counts. It's not uncommon for the PL and GL to be written on a combined basis, but it's also fairly common to see them written on a standalone basis as well. Underwriting documentation. Just the same as in the long-term care space, carriers are going to be asking for a medical or day spa application, and this is going to help us verify staff counts, revenues, payroll, and services. Prior policy deck page or indication of retro date if applicable. 5 years of currently valued loss runs, if applicable, brochures or website that outline service offerings, and then informed consent documents and licenses and certifications for the services being provided. Next slide, please. So this next claim example is one that has made national news. It's still in the early stages, so demands, liability, and settlement amounts are still unknown. But this is a great example of the concerns within this space and the reason that carriers require the previously discussed underwriting documentation during the quoting process. So this particular insured was a medical spa in Texas, and they carried a 1 mil, 3 mil PL policy with a $2,500 deductible. An otherwise healthy individual, 47-year-old wife and mother, passed away after receiving an IV therapy treatment, an elective IV therapy treatment at that. The allegations are improper care resulting in wrongful death of said 47-year-old woman. So the facts as presented, again, in various news articles, indicate that shortly after the IV was initiated, the patient was found unresponsive and EMS was called. The cause of death at this point is unspecified cardiac arrest. Again, all of this is still coming to light, but the spa's owner performed the IV treatment and does not hold any medical or healthcare license, and no other licensed health professional were present on site. The patient received an IV infusion containing vitamin B complex, ascorbic acid, B12, and TPN electrolytes. The medical board notes that TPN electrolytes require a prescription to administer or purchase, and these appear to have been purchased for the medical spa through an account using the medical director's credentials. The medical director was not on site during this procedure, and as it stands, it seems like his license has been temporarily suspended. It's a tragic event, and while we can only speculate on liability and settlement amounts, this example can help us understand the concerns in underwriting process. Do we have the appropriate level of staff performing the services, and are those services being provided under the supervision of a qualified medical director? Next slide, please. Non-emergency and emergency medical transportation. So we will be discussing the general liability and professional liability for this class, but these risks should also be carrying commercial auto liability. We've seen in the last year or so that many carriers are dialing back on the loading and unloading of passengers, which for the true non-medical transportation risks, this and abuse are going to be your predominant exposures. Loading and unloading can often be covered under the commercial auto and or the GLPL, and the market's been responding as a result of claim frequency and severity. We've seen that GL carriers are excluding loading and unloading entirely and or offering coverage at a reduced sublimit of insurance. So to start on kind of the range in service offerings within this class and kind of how things are going to be rated up, we'll start with the true non-medical private passenger transportation risks, where we're not going to have any licensed medical staff, i.e. EMTs or paramedics. These are going to be your drivers that are often certified in CPR and or first aid. So within this category, it's kind of going to start again with that private passenger transportation vehicle to a secure wheelchair transportation, all the way to gurney transports with stretchers. Moving on to the non-emergency medical transportation, there's a range between ground ambulances all the way through to air ambulances and flight ambulances. We'll stick with the ground ambulances for our discussion, but within this class, think facility-to-facility transports, i.e. a resident of a nursing home is in stable condition, but is in no condition to get into the back of a private passenger vehicle. They as such, are going to need an ambulance to transport them to the hospital. Again, oftentimes you're going to have an EMT or a paramedic on staff. You're going to have an equipped ambulance, but the lights and sirens are not running. Emergency medical transportation, on the other hand, would be 911 calls, lights and sirens, and these can range from ground ambulances all the way to med flight and air ambulances as well. Next slide, please. So for this particular claim example, we're going to discuss your pretty basic wheelchair paratransit company. No licensed paramedics on staff. These are drivers taking grandma and grandpa from their house to the doctor's office and back home. This insured carried a 1.3 GL limit with a $1,000 deductible. And the allegations were failure to properly secure the wheelchair prior to transport, resulting in a hematoma and client death. Now, this wasn't a 10-car pileup. This was a situation where brakes were applied very rapidly. The car came to a screeching halt, and the wheelchair was not secured in the back of the vehicle, causing the client to fall over and hit their head, which ultimately led to their death. Tragic event. The demand for this particular claim was $1 million. And as far as liability for the insured goes, and it's not uncommon for this type of situation to happen, but there was actually video surveillance which showed the driver failing to properly secure the client. This was very clear negligent loading and unloading of the passenger. And for this particular claim, it wasn't quite an even split, but the settlement was $1 million, and it was split between the commercial auto and the general liability policies. Next slide, please. So to kind of round out our presentation here, I wanted to finish up with underwriting criteria here for non-emergency transportation risks. These are typically going to be rated on revenues or call counts. And these policies may or may not contain audit provisions. That's something to keep in mind. Transportation risks may be written on an occurrence or claims made and reported basis. As far as underwriting documentation goes, much the same as the other two classes we previously discussed, a supplemental application is going to be needed. Revenues, staff, breakout of call counts, and types of vehicles. For example, it's not uncommon to see a transportation risk where they offer all three of the services that we previously discussed. They have wheelchair vans with drivers. We have non-emergency facility-to-facility transports in the back of an ambulance. And then we also have 911 calls that are being fielded with lights and sirens. So in order to properly rate that risk, we would need to know the breakout of call counts and revenues between those three classes to help adequately price the risk and make sure that it's adequate. Prior policy deck page or indication of retro date if applicable, 5 years of currently valued loss runs, profit and loss statement. Again, most of these are going to be rated on revenues and or call counts. And the final piece, again, we haven't touched much on the commercial auto coverage, and that's not something that we're going into in great detail today, but many carriers would also require evidence of commercial auto coverage, and a certificate of insurance or declarations page would suffice. So I'd like to thank everybody for listening, and I hope that you were able to take something from this. And my hope is that we're have a better understanding of what would fall within an allied health risk, and then also how to build a submission and ultimately get a quote and get some business bound. I really appreciate everybody listening. If there are any questions, I'll do my best to answer. But with that, I will turn it over to Lexi. And thanks again for having me.
Perfect. Thank you so much, Tyler. That was great. Thank you for sharing, so much valuable information on this industry and what classes of business to target as well. To include, here's actually a snapshot of our target classes. It's a very short list, but gives you an idea that we can write a variety of classes. We have allied health on here, also architects, engineers, real estate, lawyers, technology. We can consider new ventures, risks with claims, or even a lapse in coverage. So if you're currently working on a risk, please send it my way. I'd be happy to take a look at it and see what we can do. We have applications on our website as well at cidinsurance.com. We also have recorded webinars on specific coverages, many tools to help you along the way, such as quote templates, claim examples. And here we can see our submission email that you can submit your applications to, or you can send them directly to me. My email is listed on the slide, lexi@cidinsurance.com. Lastly, Jacob will be sending out some material to you after the webinar, and again, a short survey for you to complete so we can just get some feedback from you. So we want to thank you again for joining despite your busy schedules, and we look forward to working with you, and I hope you have a great rest of your day.